Thank you very much. Good afternoon, everyone. As being introduced, my name is Oanh, call me Oanh. I am the director of the Center for Supporting Community Development Initiative, SCDI, in Vietnam. So in my country, SCDI is known as an NGO working with the community, in particularly the marginalized community, the community that is considered as difficult to reach, people living with HIV, people who use drugs, sex workers, ex-prisoners, the homeless people, people living in slums, people living in the remote area, ethnic minority, indigenous people. They are the people I work with, we work with. So I founded this organization 15 years ago. And I founded this organization because after many years working as a doctor in the hospital, working in the clinical epidemiology center in the medical school, working as a researcher in a social science research institute, doing the evaluation of the national HIV program, doing my master on research in the UK, doing my leadership training in the US, I realized that people are labeled. We give them a sticker. This is the people who use drugs. This is the people living with HIV. This is a sex worker. And we see them as the label. We don't see them as a whole person. They are the people. When I work with them, I realize that they have a lot of talent. They have a lot of experience that we don't have. The sex worker have an experience that a researcher don't have. The drug user have an experience that a policymaker don't have. But oftentimes, they are not considered as a whole person. They are not allowed to use their full potential. So when I did the evaluation of the national HIV program 25 years ago, I felt it so painful. I felt the pain of the people living with HIV, of people who use drugs and their family because of stigma. I felt the injustice that they have to suffer. And as a human being, I felt that is unacceptable. But also, as a doctor who tried to do things, as a researcher who tried to do research, as an NGO person who wants to do advocacy, I felt that there's this vast resource that we waste. We waste because we look down at them. We don't use their potential. So I created this organization to create the opportunity for us to work together. For people who are marginalized, who are often looked down, who are often considered as a weak and need help or need rescue, to be able to use their potential. But I also create this organization for us as a researcher, as a doctor, as a manager, as a policymaker, to be able to learn to engage with them. We would not do very well if we only see them as a subject of research. If we only see them as a subject of research, they would only behave like the subject of research. They would give us the answer that they think we want to know. Oftentimes people say, oh, they may not tell us the truth. Why do they need to tell us the truth if you only consider them as a subject? So this organization, I see, because I could see the perspective of policymaker when I did our leadership program in the US and when I did the evaluation of the national HIV program. I could see the perspective of researcher when I worked in the research institutes. I could see the perspective of manager when I managed the program. And I see that we are in a different planet. So in the research planet, and we complain that the policymaker don't listen to us. The doctor living in the planet of doctor who complain that the patient don't listen to us, don't understand, etc. So this organization that I created was want to bring people together, want to bring the different planet together into a galaxy. So alone, we can be a planet, a star that's shining, but one star in the dark sky doesn't mean very much. If we bring different planets together to create a galaxy, each star can shine, and we can shine, help each other to shine, and we can light up the sky. So that is what our NGO is about. But I know that it's easy to have a dream, but to make it come true is not that easy. We need to build infrastructure. We need to build the community infrastructure. If we want to give community voice, the voice doesn't just like, okay, come and speak. No, it doesn't happen like that. They need to organize. They need to be able to capacitate to have a confidence and competency to be able to stand up and speak. But they also should not only speak for themselves as a person. They need to speak for their community. And in order for them to speak for their community, we need to organize. They need to represent. They need to be able to collect the voice of their people. So in my organization 15 years ago, the first thing we did is to advocate for community system strengthening. And together with other colleges in other countries, the Global Fund for HIV, TB, and Malaria did listen to us. And they started a community system strengthening component in the Global Fund. That is the biggest funding in the world that fund the community to organize, to have an office, to have a leadership training program, to have an organizational capacity building program. So with that funding, we build the capacity of the organization, of the community. So first to have a peer support group, and then they develop into the community-based organization, and then we support them a bit, then they link into the network of people who use drugs, the network of people living with HIV, the network of sex workers, and then we, with some support, they could get together in a platform. So a sex worker together with drug user, together with students, with young people, with religious leaders together, and become stronger. One inspire another. So that's what we had in Vietnam, and we built that. And with that network, they can represent, they can meet with people, with policymakers and researchers. But here, today, I want to share with you the story of a research project that we've been involved. It's started just like about 1 year after my organization started. It was in, I believe in 2011. I still remember very well, one late afternoon, maybe 6 o'clock. And so we have a visitor from France, a French. Dr. Didier Laurelas from ANRS. First time we met in my office, and that 6 p.m. In the winter, and we had no electricity that day. Electricity was cut off. We had to sit outside because it was too dark in the office, and we talked. ANRS got a request from our Ministry of Health to help the Ministry of Health to control HIV among people who inject drugs in Vietnam. At that time, the HIV prevalence among people who inject drugs in Vietnam was 30%. So Dr. Didier was looking for a partner, and we spent time talking. Next time we met together with Professor Nicolas Nagos, Professor Philippe Van der Peer. We talked more, and then we decided to go to Hai Phong. It is a hotspot of HIV among people who inject drugs in Vietnam. We met with the CBO, a community-based organization of people who use drugs in Hai Phong that we work with. We met with the Hai Phong Pharmacology and Medicine University. Professor Hương Dương is here. And then later on, we have Françoise Barré-Sinoussi come. We have Jean-François de Frécy come. And Then they bring more people. They bring the American funder and researcher, and we build a consortium. We spent 2 years discussing with the CBO. I still remember we spent days after days after day sitting on the floor of the office of the CBO and discuss things, and again, and this challenge and problem and issue and so on. And the CBO, of people who use drug in Haiphong, who've been working with us for many years, was so excited to hear that in some country, in France, in Australia, in the Netherlands, in New York, the HIV transmission among people who inject drug has stopped. So like, wow, can we do that? We would like to do that. So we discussed and developed a project. We was very excited. So people who use drug in Haiphong was excited with the perspective that we could stop the HIV transmission with the intervention that available, needle and syringe, methadone, ARV, HIV testing. And the researcher team was excited because I guess it's the first time that they spend so much time discussing with people who inject drug, who are so knowledgeable, who are so experienced, so committed, and so excited, and so interesting to discuss with them. So we developed an ambitious 5 years proposal. With the biggest question is that, can we stop HIV transmission among people who inject drug in the middle-income country setting with the existing intervention? 5-year proposal. We submitted to the funder. They didn't believe that we could do it. They didn't believe that we would be able to recruit so many people who actively injecting drug. They couldn't believe that we could retain them in a cohort for so many years, 5 years. So, I mean, that's reasonable, right? Thousands of people who actively inject drug and give them for years and after years. So, but I guess they thought that our project is interesting. So they said, how about you do a pilot? So, okay. So we did a pilot, 600 active injecting drug user, and for 6 months to see if it worked, the concept worked. And it worked just so well. We recruit people in much less time than we expected. After 6 months, 85% of the people came back. 85% of active injecting drug user came back. And for the rest of them, the CBO knew exactly what happened to them. Some of them was arrested, some of them moved, some of them died. So it's like everybody like, wow. And then we got 5-year project. It was in 2016, and we're still working together until 2 days. So last year, we celebrate the 10 years of our project. It's called DRIVE project, drug injection and viral infection in Vietnam. The initial project was about HIV, but then we see that the people who die mostly dies of hepatitis, of TB. So we nested it in it a micro hepatitis C micro elimination project. We nested in it a TB project. We nested in it a COVID project. We nested in it a mental health project. So many projects, one after another. Many researchers involved. We have a lot of master and PhD students. I don't know, 20, 30 papers have published from our consortium. That is for the researcher side, but from our side, as an NGO working with the marginalized population, we learned a lot from the project. After 4 years of the first HIV project, it was clear that the HIV transmission among people who inject drugs have stopped. And now we say, okay, now we know that we can stop HIV transmission among people who inject drugs. And we have a methodology to evaluate that, to prove that. So we use that concept, the methodology of the research, to use in other provinces where my organization implement the Global Fund, with the funding from the Global Fund, working with people who inject drugs. So the CBO who involved in the research, then providing technical assistance to the CBO in other provinces. So now in the province that we work, HIV transmission among people who inject drugs is rare. It's rare that we find a new case. Now we are using the similar methodology for men who have sex with men, because there's one common among the people who inject drugs and men who have sex with men is that the transmission happens within the community. So if you can stop the transmission or put people on ARV, the transmission can stop within the community. So I think it's doing, we are doing quite well. Of course, it's a different kind of population. We have a different challenge, but it is working well. And with that, we also develop our mental health program for the key population, not only for people who inject drugs, because with the mental health knowledge that we learn from the Drive Mind, that's in this project, we develop our mental health program for other key population. We get the expertise funds funding to do that. We develop the program for people who use stimulant drugs. We get funding to implement that in other provinces. We are working on TB with the Drive TB methodology. Now we are working with the community to implement our TB program, community-based TB program in other provinces. And we are so with all the experience we learn working with the community, we expand it into other areas. We work in malaria, with the indigenous people in the remote area. We started malaria project 8 years ago. And by 2023, in the area we work, there's almost no more malaria case. So we sit down with the people, the community who work with us on malaria and say, so what's your health concern now? Now there's no more malaria, and people is bored because now there's no more malaria. So what are your concern about the health concern? And they said two things. One is dengue fever, and the other one is unwanted pregnancy. So now we start to work on dengue fever. So with the support from ANRS, we are building a project with the local health authority and community on dengue fever. And last time when Didier and Eric was in that Central Highland near border with Cambodia, we met with the community, and they expressed their appreciation of the community. They are so hopeful that with this project, we will be able to develop the intervention, to work with them to develop the intervention that address the challenge of dengue fever in their community. So it's growing. But I think I have talked enough. And now I would like you to see a video, short 5 minutes video, and after that it will be open for question. The video is about a patient, a person who inject drug, who's on methadone, but still inject drug, and who participate in our Drive TB project. And once he participate in the Drive TB project, he discovered that he have a multi-drug resistant TB, and this is his story. And this video is actually made by one of our French interns. So can I have the video, please? Thank you.
Tên tôi là Lương Tiểu Hưng, quốc tịch Việt Nam, sinh sống ở Hải Phòng. Và tôi sống với vợ và mấy con trai. Tôi điều trị methadone từ năm 2020. Trước chưa bị lao là tôi vẫn bán hàng nước và chạy xe ôm. Khi tôi nhận được cái kết quả là mình mắc bệnh lao phổi mà lại lao đa kháng đấy chứ, thế tôi cũng cảm thấy chán. Tôi tư tưởng tôi nó chưa được cái kinh tế mình nó không khá giả gì cả, nên ra mổ giờ làm viện thì cũng chết mà. Tại lúc đấy tôi còn đang vẫn chơi bời, xong lại vừa uống methadone nữa. Nhiều lúc cũng muốn buông bỏ rồi, nhưng mà ra được gia đình với cả vợ con rồi bảo không đi thì chết hết cả nhà, thế hay là lây lan linh tinh. Thế là tôi cũng bắt đầu là đi khám, đi chữa bệnh. Lúc về nhà báo với cả dân dùng họ cảm thấy mình mắc cái này thì họ có vẻ mình cảm giác họ cũng kiểu như muốn tránh mình ấy. Mình bán hàng thế mình cảm thấy họ như kiểu xa lánh, mà mình cảm tưởng hàng quán nào cũng không thấy có ai ngồi, kiểu kỳ thị. Từ ngày bắt đầu nhập viện thế tôi có nghĩ là nó ảnh hưởng lớn đến đấy, hoang mang lắm, lúc nào cũng sợ mà không biết nó như nào, không nghĩ là nó lại lắm tác dụng phụ thế. Mỗi lần uống thuốc vào mặt mũi nó tối sầm hết lại trong ấy, uống cái đấy nó cảm tưởng đầu óc nó lẫn lộn, không ăn uống thì chán lắm, chẳng muốn ăn, lúc nào trên mồm mình nó kiểu nó tàn mùi kháng sinh với cả ấy này, có muốn ăn mấy đâu. Cứ đến giờ uống thuốc nghe tiếng xe các bác sĩ đi là cũng đã chán rồi. Uống thuốc methadone cũng không đủ, nên ra nhiều lúc phải chơi thêm cả heroin nữa. Tôi cơ thể người lúc nào nó yếu, là hóa ra thành ra là mình uống cái thuốc đấy nó tác dụng phụ của nó là thành ra là nó thiếu thuốc, nó vã vật, nó mệt, rồi trong xương trong thủng nó kiểu như kiến bò, nó khó chịu lắm. Nói chung là nó khó tả lắm, nó cứ buồn chồn lo lắng, xong rồi nó mệt mỏi lắm, mình không muốn ấy. Sau cái thời kỳ uống thuốc nó bị vã nhiều quá, thế là tôi mới nói chuyện với cái ông tiếp cận viên Quân ấy. Quân ấy giúp tôi nói chuyện với bác sĩ là chỉnh liều thuốc methadone cho tôi. Đi khám bắt đầu biết mắc bệnh lao thì tiếp cận viên Quân ấy cũng đưa tôi sang bên bệnh viện Lao Kiến An kia, bắt đầu vào nhập viện, họ cũng đóng tiền cho tôi, tiền viện phí viện phùng ấy. Đúng thật sự là mình cũng cũng biết ơn họ đấy, và cả chương trình nữa, từ cái chương trình đâm ra mình mới biết họ, đâm ra mình mới được qua lại, không giờ chưa chắc khéo giờ chết rồi. Tôi muốn nhắn nhủ đến với những người mà đang điều trị bệnh lao kháng này là bây giờ cái đấy nó chữa khỏi được rồi, mong họ cố gắng chữa để mà cho xã hội nó không còn bị mắc, không còn có cái bệnh đấy nữa. Nếu quá trình điều trị quá khó khăn, tác dụng phụ quá mệt, bạn luôn có thể tìm sự hỗ trợ từ các tiếp cận viên và các bác sĩ. Cứ cố gắng lên rồi cũng sẽ vượt qua được hết thôi, chứ không có khó khăn gì cả. Rồi lúc đấy có sức khỏe rồi lại làm lại những công việc bình thường mình yêu thích ấy, chẳng hạn.
We're going to take maybe one question.
Pardon. Thank you, Owen, for your presentation and for the movie. And oui, on va prendre des questions dans l'assistance, s'il vous plaît.
So we're going to take questions from the floor.
Also, because here we have people from the DRIVE team. We have a Dr. Didier Laurelas, we have a Professor Nicolas Nagold, we have a Professor Zuong Hung, we have a Delphine, who used to be a part of our team, and we have a Hong, who also a part of the team. So if you have anything you want to add or you want to comment, yeah, please.
Thanks for this great talk. My name is Aliou Balde, epidemiologist at one of the ANRS CTU in Paris. Given the actual geopolitical context, how we can sustain the funding of NGO, especially through the local funder?
There is a very big question and very difficult question, and that is also the question that we ask ourselves every day. But the truth is that if we don't invest, we don't have anything. So if the researcher or research institution want to do research well, you need to invest in research infrastructure, right? You can invest in lab, you can invest in computer, you can invest in things, but how about community structure, community infrastructure? People don't just like come when you ring the bell. We need to build the structure. We need to invest in that. So if the research institution, if the policymaker, if the program manager are really serious about doing a good job, they need to really listen and mobilize and engage with the community. And in order to do so, they need to have an investment. NGO is only like us. We work as a facilitator, as an interpreter. So interprets not only in terms of language, but in terms of knowledge, in terms of culture, in terms of understanding. So to make researcher, policymaker, and community understand each other. So we are like the bridge to make that galaxy a million planet. So we need investment. Of course, for ourselves, we keep looking for different resources and different creative ways so that we can continue to do our work. But it is a mutual responsibility. And yeah, so the government, the donor, so different institutions. The research institution, if you think that we are useful, you need to invest in us as well, or to call for the donor to invest in us. So we just don't just appear out of the thin air. So yeah. So sorry, I don't have an easy answer to your question, but that's it. Yeah. Yeah.
Okay.
Please.
Une dernière question, on a un peu de retard. Merci.
One last question, because we're a little bit behind schedule.
Quickly, I don't know if I should speak in English or in French, but in French, maybe one, because you understand very well. Juste, merci beaucoup pour cette magnifique
I want to thank you for this beautiful story that you told us about this
tu as
project.
beaucoup insisté sur l'échange en fait entre les chercheurs, les communautés, les médecins,
talks between
responsables
researchers and communities and doctors and
de
policymakers
santé localement.
and at the
Ces
local
échanges
level.
ils sont aussi
Now,
dans
these discussions,
ce cadre de la santé
these
globale
talks are also important when we talk about
du
global
sud
health.
vers le nord,
And we
quelque part,
also need
où
to
on a
have
aussi,
talks
nous,
between the north
énormément
and the south,
appris et on a
because we
essayé de
learn
transmettre
a
tout ce qu'on a
lot from
appris
that, and
ici
we
dans
try
notre pays
to transmit everything that we learned
l'équivalent
to
de ce que
people
l'on a
over here
appris
in our country.
traduit dans le cadre d'un projet
It's
financé
been
par l'agence qui
translated
s'appelle
into a
ICON, qui
project
a déjà
funded by the
été
agency, which is
présenté
called
et dans
ICON,
lequel cette approche
and
vraiment purement
in which you
communautaire chez les
really have
personnes
this
usagères de drogue
community-based
a
approach
montré une
for drug
efficacité
users.
incroyable et a vraiment révolutionné,
And it has
et
proven to be
le
very,
terme
very
est
efficient,
choisi
and it
à dessein,
revolutionized
les professionnels
mark my
de la
words,
réduction des risques des centres d'addictologie en XAPA dans les villes où le projet a été mené, que ce soit à Montpellier ou à Paris, où des usagers ont été non seulement partie prenante de façon importante dans le procédure d'élaboration du projet, mais à l'issue du projet ont été embauchés par les XAPA, les CARUD, parce que les responsables, les équipes ont vu quels bénéfices ils pouvaient apporter, non seulement lorsque les patients sont dans les centres, mais comme on l'a vu avec ce patient avec une tuberculose, après pour le soutien en dehors au quotidien. Donc on a encore énormément à apprendre de ce que tu as monté comme de cette approche en France, parce que dans ce domaine, je pense qu'on a encore des progrès vraiment à faire et votre expertise serait vraiment très utile.
Would really be very beneficial to us.
Thank you, Nicolas. And we have a pleasure of working with the French team in the last 14 years. What we appreciate the most is you really live truly to the value of liberty, equality, and fraternity that we consider us and the CBO that we work with as equal, and that liberate us to discuss with you, to share with you, for the community to share with you what they think. This is good, it is not good, we need this, this is not going to work. And you care for them. Of course, we care for them, but you also care. And I think that benefit. But when we talk about not South, oftentimes we think not to South. But couscous doesn't come from France, right? Nem comes from Vietnam, doesn't come from France. I can teach you to make nem. Some college in Africa, I can teach you to make couscous. So you don't need to bear the burden of knowing everything. It's a burden, right? You don't have to always be the one who knows everything. And I think it's, there are things that we can share. To be honest, I was so shocked to know that in Econ, there's only about like 30% of the people who are eligible get hepatitis C treatment in France. France, a country that have the best healthcare in the world, you have like 30% of the people who use drug who are eligible to hepatitis C. I mean, in the Econ, of course, to get treatment. In our Drive C, 90%. How is that possible? So I think there are things that we can share, and you know that very well. You don't need us to come here to tell you what to do, but I think there are things that we can, and I'm glad that there are things that we can share. So.
Thank you so much.